Assalamu alaikum. Let's dive into pulmonary embolism. Pulmonary embolism, before jumping into the treatment and other things, first of all, I would like to start from the beginning. Can you remember the varcostrad? Varcostrad, I remember it by she, like stasis, hypercoagulability, and endothelial damage. If we like to remember the risk factor for pulmonary embolism, we can remember it by this way. Stasis, like prolonged immobility. When prolonged immobility can happen, air trouble, bed rest, prolonged bed rest, and post-surgery. So these three are the risk factor: prolonged immobility, stasis. These are the risk factor for pulmonary embolism. Then hypercoagulable state like acquired conditions, hypercoagulable state like acquired condition like malignancy, pregnancy, pregnancy, inherited, and factor 5 Leiden. And endothelial damage is due to trauma, infection, and chronic inflammation like COPD and interstitial lung disease. Okay, now these are the approach to the patient with a suspected pulmonary embolism. So stabilize with oxygen and IV fluid. So first of all, stabilize the patient with oxygen and IV fluid. Evaluate for absolute contraindication for anticoagulation. If yes, obtain diagnostic test to evaluate pulmonary embolism. If positive for pulmonary embolism, if positive for PE, consider IV filter. If negative for PE, no further evaluation is needed. Evaluate for absolute contraindication to coagulation. If it is no, assess clinical suspicion of PE with modified Wells criteria. If PE likely, consider anticoagulation, especially if patient has no relative contraindication, moderate to severe distress. If PE unlikely, obtain diagnostic test to evaluate for PE. If positive for PE, start and continue anticoagulation, consider surgery or thrombolysis if indicated. If negative for pulmonary embolism, stop anticoagulation. So this is the actual flowchart. So how we can go for suspicion of a patient with pulmonary embolism. Okay, if there is no contraindication to anticoagulation, it should precede diagnostic testing imaging in patient with likely PE, especially when in moderate distress. Okay, this is the modified. This is the diagnostic strategy in suspected pulmonary embolism. Clinical assessment for pulmonary embolism modified Wells criteria. If PE likely, CT pulmonary angiogram. If positive, PE confirmed. If negative, PE excluded. If PE unlikely, go for D dimer. If D dimer is less than 500, PE is excluded. If D dimer is more than 500, CT pulmonary angiogram again should be done to look for pulmonary embolism. If it is positive, then PE is confirmed. Negative, PE excluded. Okay. These are the predictors of 30-day mortality. Predictors of 30-day mortality in pulmonary embolism. If clinical, like hypotension, systolic blood pressure is less than 90, hypotension, tachycardia, tachypnea, hypotension, systolic blood pressure less than 90, hypotension, tachycardia, tachypnea, hypothermia, hypoxemia, alternate mental status, history of cancer and age more than 80. A radiological is right ventricular dysfunction and lab show troponin and BNP. These are the predictors of 30-day mortality in PE. Diagnostic approach to pulmonary embolism. Suspected pulmonary embolism. If patient is hemodynamically stable, determine pretest probability. Determine pretest probability. If pretest probability is high, confirmatory testing, CT angiogram or VQ scan. With this, PE either diagnosed or excluded. If a pretest probability is low or indeterminate, D-dimer screen. If D-dimer is positive, more than 500, confirmatory testing via CT angiogram or VQ scan. If D-dimer is negative, PE is excluded. If the patient is hemodynamically unstable, assess right ventricle with emergent transthoracic echocardiogram. Normal, evaluate for other causes of shock, new dysfunction, dilatation, hypokinesis, presumed massive PE, PE in hospital mortality risk factor, age, and obstructive shock. What is the test of choice to diagnose pulmonary embolism in clinically stable patient with a high likelihood of pulmonary embolism? Modified Wells criteria P is more than 4. That is CT angiography. In patient with low likelihood of the pulmonary embolism, modified Wells less than 4 D-dimer testing can help to rule out pulmonary embolism with a high negative predictive value. A patient is thought to have pulmonary embolism but cannot tolerate IV contrast due to severe renal disease. So thinking about pulmonary embolism, but he cannot tolerate IV contrast because of renal dysfunction, go for VQ scan, also done in pregnant patient to avoid fetal radiation. Pregnant person, we cannot do contrast CT. So this VQ scan is also done in pregnant patient to avoid fetal radiation. Okay, look at the modified Wells criteria. This is a very high yield criteria to remember. 3 point plus 3 points. Clinical signs of DVT. An alternative diagnosis less likely than PE. Clinical signs of DVT. An alternate diagnosis less likely than DVT. 1.5 points. Previous PE or DVT. Heart rate more than 100. And recent surgery or immobilization. So 3 point, 1.5 point, now 1 point is hemoptysis and cancer. If it is less than 4 PE, unlikely. If it is 4, or if it is more than 4 PE, likely. So plus 3 points. Clinical signs of DVT, alternate diagnosis less likely than PE. 1.5 points. Previous PE or DVT. Heart rate more than 100 and recent surgery or immobilization. 1 point. Hemoptysis and cancer. Pathophysiology of submassive or massive pulmonary embolism. Massive pulmonary embolism, right ventricular outflow obstruction and increased right ventricular pressure. right ventricle outflow obstruction and increase right ventricular pressure, which will increase right ventricular wall tension plus increase right ventricular myocardial oxygen demand. Right ventricular wall tension plus right ventricular myocardial oxygen demand. This will increase right ventricular ischemia and infarction. And right ventricular wall tension and increase right ventricular myocardial oxygen demand will decrease coronary perfusion, decrease right ventricular myocardial supply, which will increase right ventricular ischemia and infarction, right ventricular dilatation and hypokinesis. And right ventricular dilatation and hypokinesis will decrease right ventricular cardiac output and septal deviation toward left ventricle and decrease left ventricle preload and cardiac output. Patient with massive P can present with syncope and hemodynamic collapse. So pulmonary embolism, right ventricular pressure is increased, right ventricular wall tension increase, myocardial oxygen demand increase, decrease coronary perfusion and decrease myocardial right ventricular myocardial supply, which will increase right ventricular ischemia and infarction. Okay, so four or more than four likely is immediate anticoagulation CT angiography should be done. If it is less than 4, D dimer more than 500, again CT angiography only if positive and reassurance if negative. What is the likely diagnosis in a post-operative patient with hypotension? Post-operative patient hypertension, JVD, new onset bundle branch block, hypotension, JVD, new onset a bundle branch block. That is massive pulmonary embolism. Massive PE is defined as PE complicated by hypotension and or right heart strain, JVD, right ventricular bundle branch block. Okay, management options for pulmonary embolism. All patients, unless specific contraindication to anticoagulation, very high yield. All patients should give anticoagulants except specific contraindication to anticoagulation. Inferior vena cava filter, anticoagulation, or anticoagulation contraindicated or ineffective, and low cardiopulmonary reserve. So anticoagulation contraindicated or ineffective or low cardiopulmonary reserve. Thrombolysis, pulmonary embolism with hypertension, pulmonary embolism with hypertension systolic less than 90 and low bleeding risk, and embolectomy. If failed thrombolysis or thrombolysis contraindicated with persistent hypotension and shock likely to cause of death within hours. These are the indication of embolectomy. So anticoagulation, venous, inferior vena cava filter, thrombolysis, and embolectomy. These are the four options of management for pulmonary embolism. Okay, now again pulmonary embolism management. Low risk, no right ventricular dysfunction, anticoagulation unless contraindicated. If no right ventricular dysfunction, if right ventricular dysfunction, dilatation or hypokinesis, higher risk, elevated biomarker, troponin I or BNP, no hypertension, individual strategies ranging from anticoagulation to tailored catheter-directed thrombolysis if higher risk, if massive right ventricular dysfunction with hypertension, systemic thrombolysis, and or embolectomy. Acute pulmonary embolism may present with syncope, right to may present with syncope due to right ventricular dysfunction. right ventricular dysfunction, cardiac arrhythmia, vasovagal syncope to pulmonary embolism. Can also present with mild atelectasis and bloody pleural effusion. So these are the features like syncope due to right ventricular dysfunction, cardiac arrhythmia, vasovagal response. It may be difficult to differentiate PE from right ventricle, PE from right ventricular myocardial wall infarction, which can cause again cause right ventricular dysfunction. Both can cause right ventricular myocardial infarction is less likely because dyspnea and syncope more likely to cause dyspnea and syncope more likely to cause bradycardia or arrhythmia. So right ventricular myocardial infarction, it does not cause, usually less likely cause dyspnea and syncope, and it is actually caused, right ventricular myocardial infarction actually cause bradycardia, actually causes bradycardia and arrhythmia. Okay, look at here. This is the Hampton sign, wedge shaped peripheral opacity. This is the Hampton sign, wave shaped peripheral opacity on chest X-ray. Its lateral pleural effusion. CT scan show shaped infraction. Looks like Hampton sign. Looks like this is a Fleschner sign. Proximal enlargement of the pulmonary artery. There is proximal enlargement of the pulmonary artery. Looks like Fleschner sign of pulmonary embolism. This is normal chest. So this is pulmonary aberrant pulmonary embolism and decreased with distal vascular marking and decreased with distal vascular marking. Sometimes chest X-ray shows non-specific finding that may found patients with PE most likely develop a pleural effusion due to hemorrhage and or inflammation. The effusion tend to be exudated but grossly they can associate with pain to pleural effusion. Leukocytosis and peripheral neutropenia may be seen as in pulmonary process. Acute pulmonary embolism is estimated can cause fever 15% of cases. Okay, ECG finding S1 in lead 1 there is S1 Q3 and T3. Q wave present in the lead 3 and T3. On or right heart strain, right ST depression and T inversion in the right leads AVR 256. This is rarely seen. Sinus tachycardia is common. So in pulmonary embolism, S1Q3T3 is seen, or right heart strain is T depression and T inversion in lead AVR2, AVR V5, V6. This is realism. S1 Q3 T3 prominent S in lead 1, Q wave in lead 3, T inversion in lead 3, T inversion in lead 3, and indication of right heart strain. Common symptoms: acute onset dyspnea, pleuritic chest pain, atrial fibrillation due to arterial dilatation. Okay, now some question answer discussion. Okay, now look at this question. This patient after urgent laparotomy, that means after surgery, on the fourth post-operative day, he fails while getting out of bed. Sorry, he falls while getting out of the bed. Afterward, the patient is responsive but confused. Look at the in for PE to happen, there is hypotension, tachycardia, tachypnea, hypotension, tachycardia, tachypnea. An examination should diminish breath sound At the lung base, neck veins are distended. The abdomen is soft and non-distended. The surgical side, ECG shows sinus tachycardia, very high yield. ECG shows sinus tachycardia and new right bundle branch block and a non-specific T-wave changes. Immediate resuscitation with IV fluid is ineffective. Shortly after, the pupil began to dilate and his pulse decreased to 35 per minute and he becomes unresponsive. What is your diagnosis? It is pulmonary embolism. Why? This patient fall with shock that rapidly proceed to cardiac arrest. A bedside clue help to deduce shock etiology. This patient hypotension, initial tachycardia accompanied by two signs of acute two signs of acute heart dysfunction, JBD and right bundle branch block. Given his postoperative status, thrombotic risk factor, sudden onset tachypnea, due to obstructive shock due to pulmonary embolism should be considered. So this is obstructive shock due to pulmonary embolism. When a massive PE, when a massive PE cannot eject against the acutely increased afterload, as a result, there is sudden drop in cardiac output. There is therefore a massive PE often presents with fall, syncope, as in this patient, in contrast to smaller segmental pulmonary embolism. Symptoms of focal pleural irritation or pulmonary ischemia, chest pain are less common. If right ventricular obstruction is untreated, thrombolytics hemodynamically deteriorate. Global brain hypoperfusion can produce neurologic signs, confusion, unintelli- unintelli- unintelligible speech, dilated pupil with a low output shock, like a thready pulse, decreased pulse pressure. Transition to bradycardia signifies depletion of the myocardial energy stores and commonly precedes to cardiac arrest. So initially it is the diagnosis is clear-cut pulmonary embolism, but when the pulse is decreased, then and pupil is dilated, ECG changes, then it looks like PE with PE with cardiac arrest. Okay, now this question, look at here. Sudden severe shortness of breath. She begins suddenly. Sa, says began suddenly 2 hours ago while he was enjoying his favorite television show. She also reports left-sided chest pain, worse with cough, left-sided chest pain, worse with cough. Okay, good. There is acute distress. There is high fever, temperature, blood pressure normal, a bit low, hypotension, tachycardia, and irregular pulse. Irregular pulse look like atrial fibrillation can cause irregular pulse. JVD is distended and lungs are clear to auscultation. Chest X-ray is normal. ECG show irregular RR interval with no definite P wave. So looks like atrial fibrillation and PE has association with atrial fibrillation. So this is pulmonary embolism, acute onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, hypoxia, atrial fibrillation is commonly associated with pulmonary embolism. Okay, next question. This patient like sudden severe dyspnea, right-sided chest pain. Sudden severe G's near right sided chest pain begins 3 hours ago. Okay, good. 4 days ago, uneventful elective caesarean delivery, very high yield. History of surgery. 4 days ago, sudden uneventful elective caesarean delivery. Woman examination shows a woman in moderate respiratory distress with evidence of accessory muscle mass. Okay, since chest X-ray reveals no infiltrate, heart size is normal. ECG shows sinus tachycardia. Most of the pulmonary embolism ECG comes with sinus tachycardia, and that pattern S1, Q3, T3 is a very rare pattern. But most of the pulmonary embolism usually we diagnosed in clinical setting. It is sinus tachycardia. Look at pH. Alkalosis, respiratory alkalosis, PO2 is a bit low. So it is respiratory alkalosis. In addition to supplemental oxygen, the next step is IV heparin infusion. So it is pulmonary embolism. IV heparin should be infused. Patient in this setting, according to modified Wells criteria, it is PE likely. Okay, this patient, his modified Wells criteria 6. How? Absence of more likely of the diagnosis looks like PE 3 points. There is tachypnea 1.5 point, and there is recent cesarean delivery again 1.5 point. So surgery, um, tachycardia, and absence of more likely than PE looks like pulmonary embolism. So IV heparin infusion should be done. This 62-year-old man, okay, good. Sudden onset dyspnea, non-productive cough, okay. There is fever, pressure is good, tachycardia, tachypnea, pulse is 91, BMI 36, okay. Lungs are clear to auscultation. Right knee without erythema. Right knee is without erythema warm. ECG shows sinus tachycardia, and there is a leukocyte count 6,500. Looks like pulmonary embolism. A CT angiogram of the chest should be done. Why? Because this patient is hemodynamically stable, so CT angiogram should be done. According to this patient's Wells criteria, absence of more likely a diagnosis 3 points, tachycardia 1.5 points, and immobilization due to recent knee surgery 1.5 point. So again 6 points. So looks like pulmonary embolism. So clinical criteria more likely be tachycardia, and immobilization looks like pulmonary embolism. Again look at this question. Acute shortness of breath, chest pain. Okay. There is tachycardia, tachypnea, heart rate normal, bilateral wheezing is heard. The patient's right leg is swollen. So, which of the following is most likely present in this patient? It may be pulmonary embolism and high AA gradient. Okay, now this patient acute onset dyspnea, chest pain, most likely pulmonary embolism in the setting of DVT, given her right leg swelling. There is bilateral wheezing can occur in acute PE due to cytokine-induced bronchoconstriction in response to hypoxia and infarction. A risk factor of DVT or PE include obesity, possible endometrial cancer, so our she stasis, hypercoagulability, and endothelial damage. So PE causes VQ mismatch, very high and increase from the increase from a expected AA oxygen gradient. So this simplifies alveolar oxygen PaO₂ equal to 150 minus PCO2 by 8 for patients breathing room air at sea level. The AA gradient is calculated. Okay, the short form of these, like look at the patient's age by 4 plus 4. So 1, 2, 12 plus 4 equal to 16. So normal AA gradient is like 4 to 15. It is more than 15 or 16. So normal AA, so it is high AA gradient. So this patient's AA gradient is 16, so it is high, and it is the simplified formula. This is written in here, so you can remember to find out the AA gradient with this simplified formula, patient's age by 4 plus 4, or there are other formulas too, but it is simplified. You can remember this. Okay. Okay, look at the stem ECG show sinus tachycardia. Again, hypertension, tachycardia, tachypnea, chest pain, okay, shortness of breath, okay, smoking history, looks like PE, pulmonary embolism. In pulmonary embolism, there are plenty of signs like Westermark sign, like Hampton sign, like Fleischner sign. Uh, we have already discussed those signs. Look at these. This is the Westermark sign, and this patient has Westermark sign, abrupt pulmonary artery cutoff and decreased and distal marking, decreased distal and vascular markings. And look at here, this is the Fleischner sign, proximal enlargement of the pulmonary artery. This is the Fleischner sign, and this wedge-shaped sign is called wedge is for Hampton. Fleischner is for proximal enlargement of proximal artery, and Westermark sign. Okay, so if you find these signs, this you can say that this is pulmonary embolism. Okay, pH is 7.43. PaCO2 is 35, PO2 95, D dimer is normal, chest X-ray D dimer normal. Okay, he has hypertension, not tachycardia, but there is tachypnea. JVP is normal, but she returned from a trip for Thailand, so air travel, which is a stasis, which is a risk factor of pulmonary embolism. This patient has suspected pulmonary embolism, but D-dimer is normal. Chest X-ray D-dimer is normal. We are suspecting this patient has pulmonary embolism, but the D-dimer is normal. So we are thinking that reassurance and follow-up should be the case. Okay, this patient self-resolving dyspnea, no chest pain. Okay, possible due to underlying anxiety. Her chest X-ray exclude pulmonary edema, pneumonia. Pulmonary embolism is on differential. Our DD, one of the DD is pulmonary embolism as his travel stasis. So in her modified well criteria is pretest mobility, long distance flight, although a risk factor for venous thrombolism, do not qualify as embolization as per Wells criteria, and therefore these patients modified Wells criteria is 0. This result gives her unlikely to pretest probability of the PE, and her D dimer is normal, so PE rules out. That's the way of going. Like if you're thinking about PE, it may not be. Is if P unlikely, then you should do D dimer. If D dimer is low, then P is excluded. Then you should just reassure the patient. Okay, look at this question. This question, okay, sudden shiver, shortness of breath. Okay, uh, his EGFR is very low. His EGFR is low. Ventilation perfusion scan. As his EGFR is low, you cannot do CT pulmonary angiogram to confirm. So ventilation perfusion scan shows a right low, upper low perfusion and defect with good ventilation. Perfusion defect with good ventilation. So looks like PE. What is the initial treatment? Unfractionized heparin is the treatment. This patient confirmed with pulmonary thromboembolism, untreated pulmonary embolism has mortality rate 30%. As a result, immediate anticoagulation is required unless contraindicated. There are many anticoagulant options available. Low molecular weight heparin, enoxaparin, fondaparinux, and rivaroxaban cannot be used with patients with renal insufficiency, as reduced clearance and increase anti-10 anti-10A activity levels and bleeding risk. So with these renal insufficiency, we cannot use low molecular weight heparin, fondaparinux, and rivaroxaban. In these cases, unfractionized heparin is recommended with decreased estimated GFR rate as more convenient. Its therapeutic level via activated APTT. Once the heparin produces therapeutic index, goal of APTT is more than 1.5 to 2 times normal. Warfarin is then initiated. Warfarin can take up 5 to 7 days to reach its therapeutic level. It also inhibits protein C and S and can be thrombogenic without a second anticoagulant heparin as a bridge. After reaching the therapeutic level INR, heparin can be stopped and warfarin can be continued for long term. So this patient has renal insufficiency. We cannot give these three: low molecular weight heparin, fondaparinux, and rivaroxaban. So we can give unfractionized heparin. And our goal of PTT is 1.5 to 2 times. Once heparin produces therapeutic anticoagulation, then we start warfarin, and we are using unfractionized heparin as for bridging, and then we can use warfarin for prolonged period of time. Okay. Look at here, this is the wedge shaped him. This is the wedge shape. Looks like pulmonary hemorrhage. This wedge shaped pulmonary infarct, and there is pleural effusion. Wedge shaped pulmonary infarct. Pleural effusion looks like pulmonary embolism. Okay. Right arterial pressure is high, pulmonary arterial pressure is high, but pulmonary capillary wedge pressure is normal. These two, right arterial pressure is high and pulmonary arterial pressure is high, looks like pulmonary embolism. This patient history of metastatic cancer was found unconscious and was severe hypotension and shock. He has elevated right atrial pressure and reflection of the central venous pressure and elevated pulmonary artery pressure indicating pulmonary hypertension. Pulmonary capillaries wedge pressure reflects left atrial pressure and left-sided heart function. And in an elevated pulmonary capillary wedge pressure combined with elevated right-sided pressure suggests that left heart failure leading to right heart failure. However, low or normal PCWP indicates left ventricle low or normal PCWP suggests intact left ventricular function and indicates that pulmonary arterial pressure are more likely an intrinsic process, not the left heart failure. As pulmonary capillary wedge pressure is normal, it is and this right heart failure is not due to left heart failure. It is due to intrinsic process. It is due to a acute massive pulmonary embolism can abrupt increase in right atrial pressure. And pulmonary arterial pressure, right atrial pressure more than 10 millimeter of mercury, pulmonary arterial more than 40 millimeter of mercury. This can lead to decreased blood flow through the pulmonary circulation to the left atrium, resulting in decreased cardiac output and hypotension as in these patients. Okay, look at this question. Chest pain, okay, PCI done, drug-eluting stent. Now sharp left-sided pain versus on the inspiration. Okay, BMI is 30 high. Okay, ECG shows sinus tachycardia, hypertension tachycardia, tachypnea looks like pulmonary embolism. CTPA should be done. CT pulmonary angiogram should be done. Okay, the final question. This patient has chest pain, persistent tachycardia, colon adenocarcinoma, underwent surgery. Okay, good. Now prophylactic low molecular weight heparin is given, and lung auscultation should decrease breath sound on the right side. Okay, the abdomen is soft. There is mild uh, lower extremity pitting edema. ECG shows sinus tachycardia. Chest X-ray show right basal atelectasis looks like perform CTP. A perform CT pulmonary angiogram looks like it is CT pulmonary. Looks like it is PE. PE likely. 1.5 for tachycardia, 1.5 for recent surgery, and 1 point for cancer, and 3 points for pulmonary embolism. 3 point for pulmonary embolism. So modified Wells criteria is a very important criteria for diagnosis. Thanks for watching my video. Hope you enjoyed. It's a long video, but it's a long discussion. Hope you enjoyed.